This is the AI challenge that we are confronted with. We have to acknowledge there's liabilities, but let's not miss what's really happening here. Something that's quite extraordinary and unique in our time, and it's just the beginning.
Google releases Bard,
Pausing
its
AI
competitor in the
developments
race
isn't
to
a
generative
it's
AI.
a
AI
recent
making
trend
headway
for
in
that.
helping AI treat mental illness?
Hi everybody, it's an absolute pleasure for me to be here today to interview Dr. Eric Topol, who's a cardiologist, one of the world's leading experts on AI in medicine, a researcher and just a prolific author as well. Dr. Topol, thank you so much for your time and joining us today.
Oh, thank you, Alison. It's great to be with you.
I'm sure you are out the door busy, given the time it is for AI right now and all of the potential benefits that in medicine. But before we jump into that, I realized after having read a couple of your books and loads of your papers, it occurred to me that I don't really know how you ended up being, like, you're a cardiologist, right? But how you also ended up being one of the world's foremost thought leaders in the role of AI in medicine. What was the journey for you? Were there like key moments that you can recall that sort of fed into that perspective? Because it's really a unique perspective and we're so lucky to have it in the field.
I think it was a natural progression for me. I've always tried to think of where the puck's going or where medicine's headed. And so back in the late 90s, it was clear that we were starting to accumulate a lot of data. That's when genomics was really taking off, and then we started the sequencing. And then these sensors really were clicking. A smartphone connected to the internet, and '07 with the iPhone. And it was becoming clear that the problem with data was analytics, and the solution was going to be AI. So that's where I had to kind of go into autodidactic mode, because I'm not a computer scientist, but I had to hang out with a lot of great ones, like some people you work with, and many others. So that's kind of how I got into it, and it's so exciting. I have to say, as an old dog in medicine, there's no time I can remember that's as exciting as what we're seeing right now with these foundation large language models and how they are inevitably going to transform medicine.
Let's jump in about into the sort of the large language models, and I know that you've written a lot recently on the opportunities for medicine. Could you speak to some of that? Like, do you see additional opportunities now based on specifically LLMs?
Yes, I think what's happened now with these large language or foundation models, generative AI, whatever you want to call it, is we've gone from this narrow AI, unimodal, where basically, the charge was just help me with one type of data. And now we are into multimodal, particularly with the GPT-4, which has really been the first one to cross that line. Now it's text and images. And soon we'll, even go beyond that, of course, as these evolve. So no one in medicine has been able to integrate and process all these layers of data in a given individual, no less in a population. So to be able to have models that will do that and do it, accurately and meaningfully, that's what has been holding us up. So there's so many things out of this multimodal AI, like a virtual health coach that looks holistically, not just at one thing. So, for example, in mental health, what about the interactions with your sleep and your
Right.
physical activity? You have to take data from multiple sources and in real time, being able to really extract the meaning of that data and reflect it back. So this is exciting because we didn't really have a way to do that. And now we haven't done it yet in medicine, but of course, we're on the cusp of being able to.
I think some of the focus has also been on the quality of the data. I think we've come back. I think, 10 years ago, we were all very excited about the potential of big data, and then realized it was like a lot of big noise as well. I noticed that recently in a piece in Nature Medicine, you spoke about the sort of the need for annotated, like really well annotated data sets according to phenotype and so on. Could you speak to that, like overall in terms of kind of data quality and, you know, the potential that data itself has to unlock some of these problems that we have in medicine? Where do you feel, how are you on that sort of spectrum of optimistic, disillusioned?
Yeah, no, this is a great question you're asking. I think what we have to now uh, agree is that each of us is defined by many layers of data, or at least partly defined. And so this multimodal or multi-layered data that defines our uniqueness, it's not only, you know, what is captured in various medical encounters with electronic health records, which is just only a small part of what is about us. It's also things like our genome and our microbiome and our all these other biologic layers, and then our physiome through sensors, our anatome through scans, and environmental, you know, our immunome, our, you know, socioeconomic level. So some of those are really high fidelity data. Like the genome now is really gotten complete and, you know, highly accurate. And even the gut microbiome. Sensors have gotten better and better, but some are still somewhat shaky. Our electronic records are not, you know, there's many sources. People move and the records are cut and pasted largely, 80% of what's in them, lots of errors. So it depends on which layer you're talking about. But overall, the trend is to higher fidelity of the data. And, you know, the charge here is about inputs you're getting at. If the inputs are compromised, if they're incomplete, then the outputs with AI are going to follow suit. And that's the
Right.
problem.
The garbage in, garbage out principle, basically. Yeah, I love that. I mean, you're speaking to so much that is meaningful for us as well, like the basically context, but you're speaking to it in this like multi-dimensional way. We tend to think about data captured in the context of everyday living, which of course is so, and the lived experience, which is so important for behavioral health and mental health, because of course it's that everyday lived experience that in which the problems arise.
I'm really glad you mentioned that because I kind of think of, you know, the mental health story as part of our physiome. You know, that is, we have sensors that can help objectively capture metrics. We're not using them nearly as much as I hope we will in the future to help with subjective things. And, you know, I think that will be another part of the accuracy of data or the completeness of data as we move forward.
I love the phrase that you coined of keyboard liberation. And I think this is the thing, if we can deliver true value to the physician and to the clinical relationship, like that's what I'm really interested in as well. Um, do you see that? Do you see the potential for that in terms of like clinician tooling, apart from just sort of raw kind of insight delivery or information delivery? What other kind of use cases have been knocking around in your head?
Well, the one that I think clinicians will find all of a sudden the endearment, embracement as a keyboard liberation, because over the years since the introduction of electronic records, we were transformed to data clerks. And this is really
Right.
tied into the burnout, disenchantment, and depression that's pretty widespread among clinicians. So to be able to remedy that, where their keyboard use would be de minimis. So the idea is that you would have now being tested in 2,000 doctors at the University of Kansas. They're all done through voice, or whether that's the actual clinic note, whether that's discharge summaries, whether that's operative procedure notes, and on and on. So there's lots of, this is a pluripotent story, but the immediate kind of fantasy is that the clinicians would no longer be data clerks. And we're, of course, just at the starting gate, but it looks like this is going to be a winner. Now, it still means humans in the loop. You have to review
Yeah.
these notes. But the point is, then you can say, I want the note to be in the language and the literacy level of my patient. And I want the note to then lead to nudges to the patient every X amount of days about this or that, and you basically can use this format to do things that we can't do. So it goes even beyond just this kind of magical transcription level. It goes to getting rid of having to say, I want to make the appointment such date out, the prescriptions, the coding, all these functions are just taken away from the menial task of clinicians.
Right. The pre-auth, the idea that just because the way you write a letter for the insurance company can affect whether your patient has to pay out of pocket for care or not. I mean, there's so many potential use cases, I think. In the Patient Will See You Now, one of my favorite books, how does this fit with, or I know it's very early to say, right? So this is all kind of, we're brainstorming at this point, but do you see immediate use cases or ways in which this maps onto the concept of the empowered patient?
Sure, because we tend to just think about large language models helping clinicians, but in this democratization that we're moving further and further along with, the patients are going to benefit equally or more. And the reason for that is, in fact, in this new book by Peter Lee and colleagues about GPT-4, there's a whole chapter about the empowered patient with the large language models. And I really thought that was important because the idea that you could do so much as a patient when you have this type of ability to prompt. So just today, there was a paper published about patients asking about breast cancer screening advice, which is obviously a very complicated topic. And this is the first go, but they asked 25 questions. This is the University of Maryland, and they were 88% correct, and only one was inappropriate. And so, to be able to have, instead of having to turn to the doctor, to be able to get some preliminary advice and put your data, not just a Google search, which tells you about the general population, but here's my data, GPT X. Now what do I do? And so there's going to be a lot of this. Of course, this is why we need the regulatory oversight, because it has to work well. If it gives bad recommendations, that could be dangerous.
Right, and I feel, and I've written about this too, I feel like one of those dangers is undermining the public confidence because of one or two sort of ill-informed design decisions that, a couple of players have done. So
I come back to, we have to acknowledge there's liabilities, but let's not miss what's really happening here. Something that's quite extraordinary and unique in our time. And it's just the beginning. I think most people, I recently wrote a piece about GPT-X, just because we went from ChatGPT November 30th to GPT-4 released March 14th.
Right.
This is extraordinary. It's so hyper accelerated.
Does Moore's law even apply anymore? I think we're so beyond Moore's law at this point.
Yeah, this is a new law. This is that was every 18 months. This is like something happening every few weeks. No, this is crazy stuff. But it just means it's going to get better, and we're going to start to weed out the hallucinatory behavior to some extent. It'll never get perfect. And there's still the amplification of bias and lack of fairness and privacy issues that take to another level, of course. So, this is the AI challenge that we are confronted. Just remarkable data ability to analyze, process data, but acknowledging that we don't want to rely ever on machines 100%.
What I'm hearing is very much like this is a tool, and it's going to have limitations, it's going to have benefits, but actually it's a very powerful tool that we owe it to ourselves, the world, and the potential benefit in industry to really lean into the benefit and maximize those. So as a tech optimist, do you see any places where you think that we should not tread with LLM technology or AI more broadly?
Oh, yes. I mean, I think there are concerns that are very legitimate about, the idea that we could make misinformation, disinformation in general much worse, and all the kind of whatever we thought about deep fakes and and GANs we could take to a whole new order of how. So I think this is a big problem. Is we've already seen, particularly in the last few years with the pandemic, the blurring of truth and fact-free, and a movement towards mis and disinformation. And my biggest worry is that we could see that at a new scale. Where we've already seen the beginnings of that. The large language models misused. And I'm worried about that, how it could certainly make things considerably worse. And we're not in a good state right now about that. And that's, to me, perhaps the number one concern about how this could go in a downside.
Coming to the end, we always ask everybody that we interview as well this one question, that if you could change anything in the way that healthcare is delivered today, what would it be? And I'm going to suggest that you would probably say everything, but or a lot of it.
Yeah.
But if you had to choose the number one.
It depends on what time frame you're asking.
Oh,
so like
brilliant.
Right now,
this. Break it down for us.
I would say, just liberate the damn keyboards and get the gift of time for patients and patient-doctor relations to be restored. But if you say, what do I want in 5 years? I want to get rid of hospital rooms, and only hospitals become, the place where you ICU and emergency rooms, operating rooms. But the regular hospital room has become obsolete in the next 5 to 10 years because we have the ability to do that, and we should be doing it. So, right now there's an immediate thing I'd want to see, which is let's get gift of time, let's get patient autonomy going. The ability for doctorless screening of all the common conditions that are not life-threatening, skin lesions and cancer and urinary tract infections and ear infections in children, and the list goes on and on. Let's get this stuff where, and obviously that extends to mental health as well, to support people. But I do think it's, the power and the willingness to validate things as we get more and more bold and capable over time. So the answer to the question for me is just a matter of time.
I love that dimension of time. That is incredible. I completely agree with you as well. We often talk about how the sort of the architecture of clinical services and therapy in general actually accidentally, not intentionally, but often inadvertently undermines the patient's ability to engage in a therapeutic process. Dr. Topol, thank you so much for your time and joining us today.
Oh, thank you, Alison. It's great to be with you.